Hi, this is Mrs. White, and today we're going to talk about pituitary dysfunction. The first thing that we're going to talk about today is something called acromegaly. This is a manifestation of too much growth hormone. So when we have too much hormone. If you notice, as we're talking about this, I have a concept map up here, somewhere for you to organize your thoughts and your notes. And I have it set to our next gen. So next gen NCLEX wants us to recognize and analyze cues. It wants us to prioritize hypotheses. It wants us to generate solutions, take action. So we're going to go throughout the semester and with these little snippets of information. That's how we're going to set it up. I did add relevant diagnostics and medications to know. So how do we pick this apart? Under recognizing and analyze cues, we want to assess the patterns, review the patient's chart, consider the patient and their values in this as well. We want to be able to decide relevant from irrelevant information, what information in the past medical history may be important. And analyze is more clinical. Are there patterns? Do you need more data? Prioritizing hypotheses are the possibilities, the priorities, the most pressing concerns, risks related to the solution, and risks if we do nothing. Generating solution and taking action, these are the patient goals and their expected outcomes. We want to implement the plan. These are the skills, procedures, collaborations, teaching, ethical concerns, and evaluate the patient response, and then medications to know. All right, so we'll dive right in here to acromegaly. So acromegaly, as we're going into recognizing the cues, so remember this is an overproduction of growth hormone. The main cause is a pituitary adenoma. By far and away, that's the most common cause, and almost all pituitary adenomas are benign. That doesn't mean they don't need to be treated, it just means that they're not cancerous. Some of the most common things that you'll see would be the enlarging of the facial features, hands and feet, muscle weakness and joint pain. The patient may present with a deep voice, sleep apnea, diabetes, acne, thick leathery skin, headache and visual changes. And ask yourself why. Why would they have headaches and visual changes? Well, they have a pituitary adenoma, most likely, that can cause pressure in the optic nerve. If you look at this picture here, these pictures were taken several years apart, but on the left, you can see how the lady's facial features have changed, and on the right was her baseline. So complications of acromegaly, if we don't treat it, would be cardiovascular disease, diabetes, colorectal cancer. One of the most famous people that you may know, or maybe not, you should Google this person, Andre the Giant. He has acromegaly. He actually passed away from cardiovascular disease as a result of it. Relevant diagnostics. So how do we diagnose acromegaly? Well, there's some testing we can do. We can do the insulin-like growth factor. We could do an oral glucose tolerance test. Prioritizing hypothesis. So remember what we said that is. That is the possibilities, priorities. So what can happen to this person? One of the main issues would be the risk for cardiovascular disease, pain, impaired glucose, right? Because they're at risk for diabetes. Risk of impaired oxygenation. Don't they have the potential to have OSA? Disturbed body image. So what do we want to do in order to help this patient? We want to return that growth hormone levels to normal. So how do we do that? How do we get their growth hormones back to normal levels? We could do surgery. That surgical removal is probably one of your more common. It's called a hypophysectomy, so surgical removal of the pituitary. And there's some issues with this, right? So what are some issues with a hypophysectomy? Well, they could be at risk for diabetes insipidus after surgery. So we need to monitor for that. We could have cerebral spinal fluid leaks depending on how they're doing the surgery. Most often they sort of go through just under the gum line or nasally. So let's talk about post-op care of a person with a hypophysectomy. First and foremost, we have to consider their oxygen status because after they come out of surgery, we have an airway potential issue, and then also we have to worry about cerebral edema. Remember, we're going into the brain. So what do we want to do? Easy and overlooked positioning. Elevate that head of the bed. We want to assess for cerebral spinal fluid and any leaking. And because we know that's a potential, we want to have the patient avoid any activities that could increase the risk of that cerebral spinal fluid leak. So what are some of those things that you could think of? Write them down here. Some of the things I think of are coughing, sneezing, bending over. The person could be at risk for increased intracranial pressure, so we have to monitor for increased intracranial pressure. We want to monitor for diabetes insipidus, right? So how do we monitor for diabetes insipidus? Hopefully you're checking their urine output and their urine-specific gravity. We teach the patient not to brush their teeth for up to 2 weeks. Why do we do that? Remember how they're going through the surgery that they're actually cutting, usually into the upper gum, just over the, kind of where the upper lip and the gum meet. And as a result, any tooth brushing can cause bleeding and infection. When we're taking out somebody's pituitary, remember, it's not just acromegaly that we're curing. We're also causing a host of other problems. So we're going to have to administer steroids. We're going to have to monitor their thyroid because we could have untoward and unanticipated consequences to this surgery. Generally, the patient will be on cortisone and thyroid replacement lifelong. We might need antidiuretic hormone regulating medications. Again, the pituitary has a lot of functions, so we're going to have to replace those. And then we have to target the organ support. So we might need to support the pancreas, like those target organs that the pituitary targets. Pancreas, thyroid, gonads, they might need support. Now, backing up a little bit, if somebody has a hypophysectomy and they're beginning to develop diabetes insipidus, how do we treat that? Do you know? If not, I want you to go look it up. All right, so I just want to back up to the relevant diagnostics for just a moment too, because there is something we can do too. We can also monitor their growth hormone. So growth hormone, special things for that test, they need to be NPO after midnight, so nothing by mouth after midnight for the test, and bed rest until the sample is drawn. And we'll talk a little bit more about the growth hormone stimulation test under the next section. So what are some of the medications? So some of the medication would be somatostatin analog, so octreotide, sandostatin. That's given subcutaneous 3 times a week, or the long-acting is given every 4 weeks. We have some growth hormone antagonists, so Somavert. Basically, it blocks the liver from making insulin like growth factor 1. So that's just a couple of the medications. So in a nutshell, that is what happens when we have overproduction of growth hormone by the pituitary. So now let's take a look at the next one. So what happens when we have pituitary hypofunction? So remember what the pituitary does. There's a little reminder up here of all the different organs, those target organs. So basically, pituitary hypofunction is a decrease in one or more of the pituitary hormones. So selective would be just one hormone, and pan-hypopituitarianism would be all of them. So let's go over to recognizing the cues. So tumor is the usual cause. Remember that benign adenoma. Of that, African Americans are at increased risk. You might have a pituitary infarction. Sheehan's is one of the ones I think about. Pituitary destruction. Signs and symptoms may be from the lesion itself. So signs of a lesion would be things like a headache, visual changes, loss of smell, nausea, and vomiting. Now, a clinical red flag for a pituitary adenoma with increased intracranial pressure is projectile vomiting. I want you to remember that because that's important for any sort of increased intracranial pressure. You may have changes in secondary sex characteristics, so hypogonadism. Others are basically based on the target gland, so look at what you have there. You have the adrenal cortex, the thyroid, the kidneys, the breast. So if you have pan-hypopituitary function, so we're missing all of them, the patient often presents with things like bradycardia, hypotension, hypoglycemia. Because if we have a lack of TSH and ACTH, that can be life-threatening. So relevant diagnostics, we often will use a CT or MRI because we're looking for that adenoma. We want to check the hormone levels. So growth hormone. So one of the tests for growth hormone we talked a little bit about is the growth hormone stimulation test. Basically, when we do that, we give insulin to induced hypoglycemia, which then stimulates growth hormone. So then we have to check the labs baseline at 30, 60, and 90 minutes. We look for glucose, growth hormone, cortisol. Do you see any concern with giving somebody who's not a diabetic insulin? Hopefully you do. So always keep D50 on hand. We might need to treat them. All right, so some hypotheses that we have to think about for a pituitary hypofunction. Worst thing that could happen, of course, would be shock from ACTH deficiency. That would give us a sodium and water deficiency. We have risk for surgical complications. We have risk for cerebrospinal fluid leak, risk for increased intracranial pressure, and of course, risk for DI or SIADH. Have a risk for bleeding after surgery. So generating solutions, taking action. The treatment is very similar. If we have a pituitary adenoma, then we need to take it out. That is the treatment. So surgery, which we've already discussed, how to care for somebody with a hypophysectomy. And then growth hormone replacement, so somatropin. Some of the problems with giving somatropin is that it can lead to fluid retention, swelling of the hands and feet, myalgia, joint pain, headaches. We give growth hormone in the evening. It's given subcutaneously, and we take it for life. We may need to give the person testosterone or estrogen and progesterone. Try to remember that anytime we give somebody things that mess with estrogen, we can mess with their clotting. We can cause increased clotting. And estrogen and progesterone are really not for use of anybody with a history of PE, some folks with breast cancer or prostate cancer. So remember our post-op care for the person with a hypophysectomy and all of the things that can go wrong. And then medications to know. We already talked about somatropin, that's growth hormone. And then lifelong replacement of antidiuretic hormone, cortisol in the form of corticosteroids, and thyroid replacement. So pituitary hypofunction. That's it with this section.